again. It's a Wednesday and we again have the PG teaching spine class, this time with a very eminent speaker, Dr. Rishi Kanna sir. He has done his advanced spine fellowship from Nottingham and is now a consultant spine surgeon at Ganga Hospital. He's been mentoring students and he's also a winner of quite few national and international awards. He recently belonged to the team which won the North American Spine Society Award for the best basic science paper. And today he will be taking one of the most interesting, important academic as well as clinically relevant topic, which is tuberculosis of the spine. I hope for the best. Over to you, sir. Sir, you're muted.
Yeah, thanks, Rohan, and thanks, OrthoTV, for this wonderful opportunity to get back to the students. So I'll be sharing my screen now. So this is a comprehensive review and how we'll be clinically managing our patients in our current practice. So I hope at the end of this presentation, we would be able to clear several doubts about the spinal tuberculosis with regard to how to clinically evaluate a patient with suspected tuberculosis of the spine. Is the MRI a reliable investigation to start anti-tubercular chemotherapy? Or should we perform a biopsy in all the cases of suspected tuberculosis? And when we take a biopsy, what to do with the biopsy? And if a patient has a huge cold abscess, is it mandatory to aspirate the cold abscess or can we manage him with a conservative line of treatment? When to do surgical intervention? And if at all we give anti-tubercular chemotherapy, how long should the drugs be given? There are a lot of controversies with regard to this particular question and a lot of other queries which may crop up in your mind as we go along. So let me start with the two clinical case examples. So these are the AP and lateral lumbosacral radiographs of a patient. He's a 34-year-old male who presented with reasonably significant back pain of 2 months duration. And he also had bilateral weakness in both lower limbs. The weakness was somewhere between grade 2 to 3 in both lower limbs. And he was quite febrile also. So immediately we suspected an infectious pathology in the spine and took an MRI. And in the MRI, you can see that there are a lot of signal changes in the vertebral body. So the hyperintense signal changes are present at the level of the L4 and L3 vertebral bodies. And you can see some collection present in the epidural region. So the radiologist opined that this should be a case of a patient with a spinal tuberculosis with an epidural abscess. So these are the axial MRIs. So we can see find any evidence of an abscess. It was a huge cavernous hemangioma present in the epidural space, which has actually infiltrated into the vertebral body. So we have to excise the hemangioma in total. And then the patient was further given radiotherapy. So this is one particular patient where the clinical and radiological presentation was very suspicious of spinal tuberculosis, but it turned out to be something different. Right. So I have one more case. So this is another young gentleman. He was about 20 years old, chronic low back pain. And he had a significant history of trauma. So he fell from a height of about 10 feet. And after that, he started to have low back pain on and off. And he didn't get any proper radiographic or allopathic treatment at the time of the injury. And when he presented to us 1 year later, so this was the MRI and CT picture, we can see that the L4, 3, 2, 1 vertebra is intact, but between L1 and T11 vertebra, 1 vertebra is completely absent. And the posterior elements were intact. We couldn't see any major repropulsion or vertebral body destruction per se, no abscess. And interestingly, when we did biopsy and culture for this patient, it turned out to be a Mycobacterium tuberculosis. So the aim of highlighting these two cases is that whatever we see clinico-radiologically as diagnosed as spinal tuberculosis, may not be spinal tuberculosis in at least 20 to 30% of the cases. And cases where you don't suspect spinal tuberculosis can turn out to be spinal tuberculosis. So in our country, we should have a high index of suspicion and a low threshold to evaluate histopathologically in patients suspected of spinal tuberculosis. So I have divided the presentation into 3 parts. In the initial part, we will go through the epidemiology, pathophysiology, and clinical features. Among the skeletal system, the spine is percentage of all skeletal tuberculosis. So next to the lungs, the spine is the most common site to be affected by the Mycobacterium tuberculosis organism. And within the genus Mycobacterium, there are about 63 species, but most common infections are caused by this tuberculosis species. And typically it affects the lower thoracic and lower thoracolumbar spine. The reason being the high vascularity of the vertebral marrow. So the vertebral body is the region which is typically affected, almost 9 times more common than the posterior elements of the spine. The second reason why the thoracolumbar spine is affected is because of its proximity to certain structures which are easily susceptible to tubercular infection. For example, the lymphatics, the cisterna chyli, kidneys, the lungs, the lymph nodes, they all carry the tubercular bacilli whenever there is an infection in a patient, and immediately it gets lodged in the thoracolumbar spine. So about 10 million new cases are diagnosed every year. This is general incidence of tuberculosis, and 1.2 million people die due to the disease every year. So this is almost 10 times then more common than what we had due to corona in a particular country. And among these cases, most of the cases happen around the Southeast Asian region. So the India, China, Philippines, Pakistan, these regions are the ones which are contributing to majority of the total world cases. So why this organism is very difficult to diagnose, very difficult to treat, the long duration of antibiotics is required, and why is it not possible to eradicate the infection? So even though we know about this organism for more than 4,600 years, there are evidence of spinal tuberculosis even in mummies, but still we are not able to remove this organism from the human body. So the reason being, it's a very fastidious organism. It has a high lipid and peptidoglycan rich cell wall, which prevents the penetration of the human immune system as well as the antibiotics, whatever we are going to prescribe. And it's not a very rapidly multiplying organism. So only when an organism is multiplying rapidly, our antibiotics work very effectively. And it is acid and alkali fast, so very difficult to stain it in clinical specimens. So we need a special stain called the Zeal-Nielsen stain. And in a favorable condition, it multiplies fast. That is the situation we see in patients with infection is never the primary infection. So an infection has happened somewhere in the body. Usually it is either the lymph nodes, the kidneys, the lungs, or the gastrointestinal tract, or the pelvic organs. But it may not be evident clinically. And when it spreads to the spine through the arteries, the hematogenous dissemination is the most common mechanism of spread of the infection. The spine gets affected, and when the spine gets affected, it usually becomes clinically evident. So the second most common route of spread is through the Batson's paravertebral venous plexus, and also through the lymphatics. So these lymphatics are the ones which are the source of spinal infection, which happens by proximity spread. Microscopically, this slide is very important. So we have to make a diagnosis of spinal tuberculosis based on this histopathological examination. Sorry. So the classical histological examination has to be made based on these 3 observations. So presence of epithelioid cells. So these are epithelioid cells are basically modified macrophages which are not able to digest the tubercular bacilli, convert into epithelioid cells. And these epithelioid cells sometimes coalesce together to form multinucleated giant cells called the Langhans giant cells, and caseation necrosis. So this typical lesion is called as the tubercle, which is a combination of caseation necrosis, epithelioid cells, and Langhans giant cells, based on which a confirmation is made. So macroscopically, what happens when the bacillus spreads through the arteries from a primary focus and gets lodged in the subchondral marrow on either side of the disc. So as you can see in this picture, when it spreads, it reaches on either side of the disc. The disc per se is never primarily infected by the Mycobacterium tuberculosis, and it lodges on either side of the disc on the adjacent vertebral end plates. And once the vertebral end plates are affected, then by contiguity, the organism can enter into the disc by affecting the nutrition of the disc. So what happens further? So at this stage, the diagnosis is not made and the patient continues to have progressive destruction. What happens is there is, because of the bacillar enzymes, there is osteolysis. The vascularity of the bone increases because it is a chronic granulomatous infection. So the vascularity increases. When vascularity increases, the bone becomes weak. So there is severe osteoporosis. And sometimes there is occlusion of the small vessels that supply the vertebral bodies. So all these three things put together results in a vertebral body collapse. So the vertebral body collapse is a pathognomonic feature of spinal tuberculosis. So vertebral body collapse subsequently leading to infiltration of the disc and collapse of the disc space. And these two things, the collapse of the disc space and vertebral body collapse, are the reason for the kyphosis. So tuberculosis and the word kyphosis, they all go in together. And the reason is being collapse of the disc space and vertebral body collapse. So this vertebral body collapse also is the reason for retropulsion of the bone into the spinal canal. So abscess, which is a secondary response of the human body to the spinal infection, also contributes along with these two things, the local kyphosis and retropulsion of bone, to result in neurological deficit. So a patient with spinal tuberculosis has kyphosis and neurological deficit, and this is the pathophysiology for the development of these. So in the time before the development of CT and MRI for the diagnosis of spinal tuberculosis, X-ray was the classical investigation. So based on which 4 different types were described. So these are called the 4 classical patterns of spinal infection. One is a paradiscal type, which we discussed earlier. Second one is a centrum type, where predominantly one vertebral body is affected. So instead of 2 adjacent vertebral bodies on either side of the disc, one vertebral body is predominantly affected. This is very common in children. Third type is a posterior type, where only the posterior elements are affected. Again, this is an uncommon type of infection. And the last type is the non-osseous type. So non-osseous type is the one where the bony destruction is very less, but there is huge extensive pulse. So this is a paradiscal type. So you can see one disc is affected and either side of the disc, you can see a paravertebral infection. So this is the centrum type. So you can see the adjacent vertebral bodies are intact, whereas one vertebral body is completely affected. So this is the posterior type, the third one, where you can have an infection of the spinous process. And this is the non-osseous type. So we can see there is a huge abscess in the iliacus muscle, and we don't see any vertebral destruction in the iliac or the sacral bone, right? So these are the 4 classical types of spinal tuberculosis. So coming to the clinical presentation, how does the patient present? So literature has shown that the most common presentation is axial pain. So almost 90 to 100% of patients with spinal tuberculosis have axial pain. And second is constitutional symptoms like fever, malaise, fatigability. This is not very common. It is present in only 50 to 70%. So unlike a pulmonary tuberculosis, only 50% of the patients may have constitutional symptoms. So this should be remembered. Paravertebral abscess, again, seen in 50%. Fourth important thing is the presence of kyphosis. So like I told, tuberculosis and the word kyphosis always are like husband and wife. They always go together. And the last thing is the neurological deficit. So neurological deficit, the incidence varies from 30 to 60%, depending on which stage of the disease we are able to diagnose the patient. So we'll go each of these conditions one after the other. So before we go to the individual local symptoms, one should always remember that it is a systemic disease we should always look for primary infection. For example, this patient had a multifocal spinal tuberculosis, and when we did a chest X-ray, there was a pleural effusion on her right side lung. So this is very important to diagnose. So coming to the local clinical features, so 100% of the patients will have axial pain, depending upon which region of the spine is affected. So if it is the neck, cervical spine, the neck pain is a common feature. Upper thoracic spine, if the patient has infection in the thoracic region, pain in the low back region, so you should think about a thoracolumbar or a lumbar infection. So the pain can be of different types. So at the start, it is a nagging or an aching kind of pain due to the presence of the abscess. But once the patient develops a pathological fracture of the vertebral body, so when he develops a fracture, there will be severe pain, which is called as the night cries. So this is again a diagnostic feature of patient with spinal tuberculosis. This is a classical sign which used to be very useful in patients who had tuberculosis of long-standing. So when they develop instability, they support their own spine with the help of their limbs. So for example, this child had an upper cervical infection. She has to hold her neck always so that her spine could be protected. And this boy had to rest his upper limbs over his thighs so that he could stabilize his spine. So this tripod sign is an indication of spinal instability due to spinal tuberculosis. Coming to the constitutional symptoms, like I told, 50% of the cases may have constitutional symptoms. But again, it's uncommon as seen in patients with pulmonary tuberculosis. And any patient with malnourishment, we should be wary of these clinical constitutional symptoms. Coming to the cold abscess are usually present deep-seated within the spine, but they find their way out of the spine through the perineural, perivascular, intermuscular, subpleural, or one of the retroperitoneal areolar spaces, and can present in a subcutaneous plane that may not be the level of the spine that is affected. So for example, this is a patient, you can see there is abscess everywhere in the body, everywhere in the spine. So there is a gluteal abscess on either side, there is a presacral abscess, there is abscess in the iliacus muscle. So this patient had only an infection around the thoracolumbar region, but the abscess formation is exuberant and present everywhere in the body. And usually these abscesses are typically called as cold abscess because they are fluctuant and not warm, unlike what we see in an acute pyogenic abscess. Usually they respond very well to anti-tubercular treatment. We don't need to let out the abscess unless otherwise there are any pressure on neighboring structures, vital structures like a tracheal occlusion or an esophageal occlusion. We don't need to surgically let out these abscesses. Coming to the fourth cardinal feature of spinal tuberculosis, kyphosis deformity. So since the vertebral body is affected, kyphosis is inevitable in spinal tuberculosis. And depending on the number of vertebral body affected, if it is only single vertebral body affected, whereas if there are 2 or 3 contiguous vertebral bodies affected, you get a local gibbous. Whereas sometimes multiple vertebrae are affected and the deformity gets neglected, a child can develop a rounded kyphosis. Coming to the fifth diagnostic feature, neurological deficit. So any patient with a spinal tuberculosis, due to the presence of 3 things. One is the abscess, presence of retropulsed bone, and presence of spinal instability, the patient can develop a neurological deficit. So the unique feature of spinal tuberculosis is a neurological deficit can develop both in the active and the late stages of the disease. Whenever we think that spinal tuberculosis is completely healed, also the patient can develop a neurological deficit. That is one unique feature of spinal tuberculosis. So in active stage, it is because of abscess, granulation tissue, sometimes dislodged sequestrum due to the pathological destruction of the bone, and instability. Whereas in the healed stages, when the patient develops a chronic kyphosis, the spinal cord gets stretched over the apex of the kyphosis. So this apex of the kyphosis is called as the internal gibbous. So similar to what we see outside, there is an internal gibbous which is stretching the spinal cord, and one fine day the patient can develop a neurological deficit, even though the disease has been completely eradicated from the body. So we'll go to the next section of the spinal tuberculosis. So far, we learned about the basic epidemiology, microscopic observation, basic pathophysiology in terms of microscopic evaluation, and how do they present clinically. Coming to how to make a diagnosis of spinal tuberculosis. So spinal tuberculosis is one disease where we cannot say one investigation is better than the other, or one investigation is enough to make a diagnosis. We have to use all four of this. So we have to clinically evaluate the patient. We have to look at certain laboratory parameters. Microbiologically, the biopsy, the tissue specimen is very important to make a diagnosis, as well as radiological evaluation. So we will go one by one. The first is the laboratory investigation. A lot of blood tests are unfortunately made in patients with spinal tuberculosis, but only few tests are actually very useful in management of a patient with suspected spinal tuberculosis. So we know that the erythrocyte sedimentation rate is elevated in patients with spinal tuberculosis. It's a very highly sensitive test. Rarely patients with spinal tuberculosis have low ESR levels, right? But it is a very non-specific investigation. So, but it helps us to think that there is something chronic inflammation is happening in the patient. Second use of ESR measurement in spinal tuberculosis is after starting anti-tubercular treatment, usually by 3 to 4 months, it tries to normalize. So if there is a failure of normalization of ESR value, we have to suspect a coexistent other infection or a drug-resistant infection. Second blood test is C-reactive protein. Again, it is an acute phase reactant. It is not very helpful, but to differentiate a pyogenic infection from a spinal tuberculosis, we do a CARP test. Third thing is most of the anti-tubercular drugs are hepatotoxic, so we need to have a pre-chemotherapy status of the liver function, so that we need to do liver function tests. So ARP, total counts, and liver function tests. The second group of blood investigation, laboratory investigations are called the immune response tests. So there are two immune response tests. One is the Mantoux test. So this Mantoux test is positive in a patient who has a previous exposure to the tuberculous bacteria. So it doesn't mean that the patient is having an active infection within the body. So if the patient has been previously exposed and he can mount a immune response, it indicates that the patient has been previously exposed. So it doesn't have any role in a country like India where the tuberculosis infection is endemic. So we all have tuberculosis immunity. So even if you have a positive Mantoux test, that doesn't mean that we have an active tuberculosis infection. But in non-endemic countries, for example, Western countries, if there is a positive Mantoux test, then it indicates that they have an active tubercular infection. Another commonly performed test is the quantiferon or interferon TB gold test. So again, it is similar to Mantoux test, but instead of doing it in the skin, it is performed in the lab. Again, it indicates that the patient has been previously exposed to tubercular bacilli. There are a lot of other investigations like ELISA for antibodies or blood-based TB PCR. So these tests do not have any role in the diagnosis of spinal tuberculosis. So the consensus is what you can tell in the exam or what we can use in clinical practices. Suspected patient, you can do a complete hemogram, ESR, liver function test. And there is no role for Mantoux test or interferon gamma test in an endemic country like India. And IgG, IgM antibodies, ELISA test, blood PCR test should not be done. It has been banned by WHO to be done in endemic countries with suspected tuberculosis. So next investigation, what we do is the radiographs, MRI, and rarely CT image. Radiographs and MRI are very helpful in diagnosing spinal tuberculosis. So in early stages, it's very difficult to make a diagnosis of spinal tuberculosis because it is a very chronic infection. It takes up to 3 weeks for the findings to show up. So, but there are certain typical radiographic observations by which we can make a diagnosis in patients who have infection for more than 1.5 months. Typically, we see some vertebral osteoporosis, narrowing of disc space, very classical of spinal tuberculosis, paravertebral soft tissue shadows. So these paravertebral soft tissue shadows, which we see in the AP radiograph, are called as the bird's nest appearance and very typical of spinal tuberculosis. In advanced cases, it is easy to make a diagnosis because you see extensive vertebral destruction of the vertebral bodies, and there will be kyphosis, collapse, retropulsion, translation of the vertebral bodies. All these things could be present, but at this stage, there is no point in making a diagnosis. So by this time, the patient's disease could have been quite advanced. So our aim is to pick up certain subtle signs like decreased disc space, subchondral osteopenia, in diagnosing patients with early tuberculosis. But whenever you have a suspicion of spinal tuberculosis, if the radiographs are not conclusive, so you can go for an MRI scan. But then what is the role of CT scan? CT scan is mainly useful in regions like cervicothoracic region, which are not very typically clearly seen in a radiograph. It also helps to do a percutaneous biopsy. So if you are not well versed in doing a C-arm guided biopsy, one can do a percutaneous CT guided biopsy. So that is the main role of doing CT scan. And sometimes when you're planning to do a surgery, so if you are planning to insert some pedicle screws, then you need to have an idea of the status of the pedicle, so for which CT is done. But most of the radiological diagnosis is made by radiographs, and more importantly by MRI. So MRI is the gold standard radiological investigation. Just like you have a chest X-ray or a chest CT for a patient with suspected pulmonary tuberculosis, MRI is the gold standard for spinal tuberculosis because it makes an early diagnosis. Even before we can pick it up in radiographs, MRI will show destruction. So there will be hyperintense signal changes, there will be presence of abscess, and we can see the extension of the disease into the soft tissues, how far it has gone into the spinal canal or the paravertebral soft tissue shadows, and the presence of multifocal lesions. So it's quite important to have a whole spine sagittal imaging of the patient, even though they present with symptoms related to one particular area, because there is a 70% incidence of skip lesions, even though the patient could be asymptomatic. And finally, we also use MRI to assess response to treatment and regression of the disease. So this is one of our studies where we found that certain MRI findings were diagnostic of spinal tuberculosis. So the abscess wall is very thin and smooth. If there is subligamentous spread of the abscess across multiple vertebral levels, and if the vertebral collapse is more than 50%, then it indicates that there is a high possibility of tubercular spondylitis instead of a pyogenic infection. So now earlier we saw the blood investigations. Next we saw the radiological investigations. The third, the tissue analysis, are the ones which are considered as a gold standard investigation to confirm the diagnosis of spinal tuberculosis. So this has three parts: a bacterial culture or a tubercular culture. Second is the gene expert test, and third is the histopathological examination. So when you take a tissue either through CT or through image guidance, you take a tissue and send it for these three tests. So important test is the tubercular culture. So if you can grow the organism in the culture media, then it is 100% sure that the patient is suffering from spinal tuberculosis. But it's very difficult to isolate the organism in tubercular culture because tubercular infection per se in the spine is a paucibacillary infection. So there are only 10 to the power of 4 bacillus per ml of tissue. Then it's very difficult for the bacillus to grow. Whereas if the patient is having a pulmonary tuberculosis, there will be a lot of bacilli within the sputum. So it is easy to grow in a pulmonary tuberculosis. Second important test, which have completely revolutionized the management of spinal tuberculosis, is the gene expert test. So it is a PCR-based DNA test. It can diagnose the presence of DNA sequences in the tissue within 90 minutes. And it is also good because it shows the presence of rifampicin sensitivity or resistance. That indicates that the patient could be having a drug-resistant infection. So we can start earlier multi-drug second-line treatment in patients with rifampicin resistance. So third is the tissue analysis, like I told earlier. So presence of Langerhans giant cells, epithelioid cells, and cacheation necrosis. So these three are present. It almost confirms the diagnosis of spinal tuberculosis. So biopsy is mandatory. So in our setup, we perform biopsy in all patients, even if they present with classical clinical features or classical MRI evidence of spinal tuberculosis for the reasons I listed out earlier. So either it can be a CM guided or a CT based transpedicular core cut biopsy. So advantage of CM guided is you can use a wide bore needle, whereas the advantage of CT is it can exactly localize the lesion where exactly the vertebral body is affected. Take as many multiple tissues as possible so that the organism could be grown in culture. There is no need to stop antitubercular treatment. So unlike a pyogenic infection, there is no need to stop antitubercular treatment before doing a biopsy. So when will you not do a biopsy in a patient with suspected spinal tuberculosis? If the patient is already a known tuberculosis patient, so he already has a ileocecal tuberculosis or a pulmonary tuberculosis, and presents 1 or 2 months down the line with axial pain, you do an MRI and you see classical MRI findings, then there is no need to do a biopsy in that situation. So that summarizes the second part of the spinal tuberculosis presentation. So radiographs are the first line of investigation, suspicion of spinal tuberculosis. Biopsy is essential. Tubercular culture and histopathological examination are the gold standards for diagnosis. So coming to the management, so the third vital part of patient with spinal tuberculosis. So we all should remember that antitubercular chemotherapy is the mainstay of treatment for spinal tuberculosis. So even if you surgically extirpate the disease, completely eradicate the disease, there is a possibility the infection is hiding somewhere systemically, and the patient should go through a standard antitubercular chemotherapy for the prescribed duration. And what are the classical surgical indications? There are no definitive indications like we have for other diseases of the spine, but these are generally agreed upon by all experts. Patients with neurological deficit, patient with severe infection, and patient with kyphotic deformity. So we can place the patients in 3 groups: neurological deficit, severity of the infection, and extent of kyphosis. So if there are severe neurological deficits at presentation, it's better to treat the patient by surgical stabilization and decompression. And during chemotherapy, if the patient is already on medication, but there is new onset deficit, the deficit is not improving, there is a worsening of deficit, then there is no point in waiting. In this era of modern spine surgical intervention, surgery should be considered. Severity of the infection. So if there is a complete one vertebral body is fully affected, there are spine at risk signs in children. So we all know there are 4 spine at risk signs in children. If at least 2 signs are present, then there is a need to surgically intervene. And even after 6 weeks of chemotherapy, the patient continues to have significant pain, consider a surgery. Presence of kyphosis. So usually one vertebral body involvement leads to 30 degrees of kyphosis. So if there is 2 or 3 adjacent vertebral body involvement and the extent of kyphosis is increasing, again in surgery is advised. All other patients are treated effectively by antitubercular chemotherapy. So if you look at the evolution of management, it has been quite a historical story. So I will just go through it in brief. So before the 1970s, tuberculosis used to be a very bad disease. It was almost as severe as what we are managing with cancer these days. So treatment of tuberculosis was very gloomy with the significant morbidity and mortality before the 1960s. But by the 1960s, one after the other, all the 4 antitubercular drugs were invented. So then they found that with combination chemotherapy. They gave 4 drugs and the disease control was excellent. But still some of the patients had persistent kyphosis and neurological deficit. So that's the time Hodgson and Stock in Hong Kong popularized the concept of radical anterior surgery along with chemotherapy. So they completely eradicated the disease like as if you're doing for a tumor surgery, and again treated the patient with anti-tubercular chemotherapy. But at that time, the problem was that the anti-tubercular drugs were good, but the reconstruction of the anterior defect with vertebral body grafts were inadequate, and a lot of patients had complications, and their results could not be reproduced by every other surgeon across the world. So that is the time our own Professor Tuli came up with the concept of middle path regimen. So he treated all patients with anti-tubercular treatment, good bed rest, oxygen, good air, lot of nutrition, and with medications. And he found that a lot of patients improved with medications. And surgery was restricted to select situations only. And he reported excellent outcomes. So since then, the middle path regimen is the standard treatment prescribed across the world. So uncomplicated disease is still a medical problem, treated with combination chemotherapy, and surgery is advised to prevent and treat certain complications with specific indications. So what are the principles of anti-tubercular chemotherapy? Why are we giving the drugs over a long period of time? So as we discussed earlier, this tubercular mycobacteria, they have a very stringent cell wall, and they have very low permeability to standard antibiotics. So 1 or 2 antibiotics is not going to eradicate the bacillus. And in each bacterial colony, there are different types of bacilli with different growth kinematics. So some of them are rapidly multiplying, some of them are very slowly multiplying, some of them are really dormant. So we need different kinds of antibiotics which will attack these different bacteria with different growth dynamics. So that's why we give a multi-drug regimen. So these are the primary first line of drugs. 5 drugs are there, which go by the name isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. So whenever they ask in the exams what would be the dosage of these drugs, so no one should say like 600 milligram or 450 milligram. You should say by per kg body weight. So one of the important reasons why anti-tubercular drugs are not effective in spinal tuberculosis is the drugs are not given weight basis. So this is the way we remember the dosage: 5 milligram per kg, 10, 15, 20, and 25. Second line drugs are also effective, but they are less effective, more toxic, and more expensive. And these are usually prescribed under the guidance of an infectious disease specialist. So whenever you make a diagnosis of drug-resistant tuberculosis, it has to be treated under the guidance of an infectious disease specialist. So this is the current index TB guidelines published in the WHO manual. So unlike a previous treatment where we used to give the drugs 3 times in a week, a thrice weekly regimen was initially prescribed, but now the standard treatment is daily treatment regime. The drugs has to be given every day of the week, and the drugs are given in 2 phases. The one is the intensive phase where we give 4 drugs to destroy the rapidly multiplying organisms. Second is the continuation phase, low multipliers at the dormant bacilli. So 2 months of 4 drugs: HRZE, isoniazid, rifampicin, pyrazinamide, ethambutol for 2 months, followed by 10 months of 3-drug regimen. So this is the standard current prescription. But spinal tuberculosis is one situation where you have to reevaluate the patient at the end of 12 months with an MRI scan to see how the patient has completely recovered from the infection. If you suspect there is a persistence of infection, it has been prescribed that drugs can be given even up to 18 months. So how are you going to monitor the response to treatment? So we evaluate the patients clinically. We check for their appetite, weight gain, how the pain has improved, how the muscle spasm has reduced. We do hematological assessment. So we do ESR and liver function tests and see whether the patient is responding to the drugs. We take radiographs. The abscess shadows should decrease in size. More importantly, we should see bone sclerosis. At the beginning of third or fourth month, there will be sclerosis of the bone. And at the end of 9 to 12 months, there will be complete bone fusion. So complete bone fusion indicates that the bacteria is completely healed from the spine. MRI signs of healing are very important. We standardly do MRI at the end of 9 months for all patients with spinal tuberculosis to see how the patient is recovering. So resolution of marrow edema. So initially what we saw as hyperintense signal should be replaced by fat, and all the abscess should have become completely resolved. So this is a classical example, a patient with, you can see there is a L4-5 spinal tuberculosis with a huge abscess in the intradiscal and the prevertebral region. So 6 months down the line, we have done a MRI. So you can see the abscess has decreased in size, but still it is present. And you can see the bone is healing now. So there is a progressive bone-to-bone healing happening. And 9 months when you do a radiograph, so you can see there is complete interbody fusion. And in the MRI, you can see the abscess has become completely resolved. So this indicates the patient has completely recovered with antitubercular chemotherapy alone. So coming to surgical treatment. So we have decided to treat a patient with surgery. Treat a patient with surgery. And what type of surgery are we going to perform in the patient? So surgery, there are standard goals. So decompression of the spinal cord. Deformity, so we are going to manage the kyphosis. Stability, we have to stabilize the spine. So stability in the spine also helps in disease eradication, and unstable spine will result in spread of the infection. So it goes by the mnemonic DDS. So decompression, deformity, and stability. So we drain the large abscess present in the paravertebral region. So we decompress the spinal cord with laminectomy and a transpedicular decompression of the abscess. We correct the kyphosis. How are we going to give stability? We are going to put pedicle screws with or without reconstruction of the anterior column with some cages. So this is the goal of surgical treatment in spinal tuberculosis. So these can be done by 3 different approaches. One can do a direct anterior surgery and stabilize. All 3 goals can be performed through this approach. We can do an all posterior approach, the anterior column from behind. And those days, these 2 things were performed through 2 different approaches. So posteriorly, they fix the spine and then do an anterior approach to reach the anterior part of the spine and fix it. So coming to the first approach, anterior decompression. So what exactly we do is we do a anterior approach. So for the thoracic spine, it is through the intercostal space or through the rib. For the cervical spine, it is through the classical Smith-Robinson approach. And since the disease is happening anteriorly, so the vertebral body is the place which is affected by spinal tuberculosis. We are directly into the region where the disease is affected. So we completely remove the abscess, remove all the necrotic bone. We can do a nice reconstruction and then fix a plate. So classically, like I told, it is performed in the cervical spine through the Smith-Robinson approach, in the thoracic spine through the transthoracic retropleural approach, and in the lumbar and thoracolumbar region through the retroperitoneal approach. So this is a classical example. This patient had a lesion of the 3, 4, 5, 6 C6 vertebral body. You can see completely destroyed, pre-vertebral abscess and post-vertebral abscess with cervical myelopathy. So we had gone anteriorly, completely removed the vertebral body, decompressed the spinal cord, reconstruct the defect with the vertebral cage and fixed with the plate. So current situation, this is one of the commonest indications for doing an anterior approach. Predominantly for the thoracic and lumbar region, we are doing more and more posterior approaches only. So like I told, combined approach, we fix the spine posteriorly with pedicle screws and then go anteriorly, decompress the spinal cord. So this gives a global stabilization. And so this is a classical example, a child. So the child had you can see there is 2 or 3 vertebral bodies are affected. There is a kyphosis, huge epidural abscess with neurological deficit. And we went from posterior, fixed the spine, and then went anteriorly, debrided, and then placed a fibula strut graft. So you can see that the strut graft has been placed in the middle of the spine. So current standard of surgical care is the all posterior approach. Most of the thoracic and the thoracolumbar lesions are approached the posterior approach. The advantage is that it is a very familiar approach for us. So spine surgeons are very well trained in posterior approach. So we expose the spine, fix the spine posteriorly at least 2 or 3 levels above and below the affected region, then do a laminectomy, and then we can do a transpedicular decompression of the spine, let out all the abscess, and if there is a need to reconstruct the anterior column, we can do the pedicle or the anterolateral route through the same approach. So it's a familiar approach. So it provides a excellent exposure for circumferential decompression of the spinal cord. If there is a need, the bone is not very strong. If we have to extend the fixation, we can go easily 1 or 2 levels above. An anterior approach, it's very difficult to do this. So like I told, the anterior reconstruction can also be easily performed through the posterior approach. So these are some examples. A patient who had a spinal tuberculosis of the thoracolumbar region, a young child. So debridement, fixation, and then we have done a posterior column shortening and fixation of the spine. So this is another example where we have reconstructed the anterior column also by placing a cage to the posterior approach. So one vertebral body is completely affected. So this is at the level of T3. So fixation has been performed from T1 to T6, and then a cage has been placed anteriorly through the left side transpedicular approach. So we have come to the end of this presentation. So tuberculosis, it continues to be a major health problem in our country. So with increasing migration, increase in the incidence of HIV, old age, diabetes mellitus, cancer chemotherapy, all of these will lead to decreased immunity. And we are seeing increasing number of patients with spinal tuberculosis. So we discussed the classical 5 clinical symptoms: axial pain, constitutional symptoms, presence of a cold abscess, kyphotic deformity, and neurological deficit. So this should be critically evaluated. And we had radiological evaluation, X-rays useful in the later stages. MRI should be done with a low threshold. In the lab investigation, in the blood tests, ESR, liver function tests, and complete blood counts. And there is no role for Mantoux test or an interferon gamma test in diagnosing spinal tuberculosis. And if you have a suspicion, always perform a biopsy. So either a CM guided or a CT based biopsy. And you have to send for 3 investigations: so gene expert test, histopathological examination, and a tubercular culture. Take as many tissues as possible so that the diagnosis is made with good confidence. And medical management, so it cannot be further reinforced. So this is the key and ultimate weapon in our armamentarium to treat a patient with spinal tuberculosis. So the drugs are given weight-based. 12-month regimen is the prescribed regimen according to the WHO. So 2 months of intensive therapy with 4 drugs and 10 months of continuation phase with 3 drugs. And the surgical principles are typically followed in three important situations: whenever there is a worsening neurological deficit, whenever the extent of disease is very severe, and third thing, the patient is having severe kyphosis. We can do either an anterior approach or a posterior approach. Of late, most of the surgeons are preferring a posterior approach, where we can stabilize the spine and also reconstruct the anterior column through the posterior approach itself. Thank you. Thank you for your kind attention. And Rohan, if there are any questions, we can take it up.
Yes, sir. Any questions from the audience? All the postgraduate residents? I think it was quite an extensive topic, covered very nicely in a much more simplified algorithmic manner. However, if you all have not understood anything, please come forward and ask your questions and doubts. Anybody?
There is a question in the chat box, Rohan, from Abdul. He has asked, sir, is infection involving the spinal cord or is it limited to bone only? So he has asked whether the infection is present predominantly in the bone or does it affect the spinal cord? So the meninges, the dura mater, arachnoid, they provide a strong protection against the spread of the tubercular bacilli. So very rarely only you have a situation where the bacteria has entered into the spinal cord. 99.9% of the time, it is an infection of the vertebral body and the disc alone. Only the abscess which forms within the spinal canal compresses the spinal cord and then causes a neurological deficit.
Sir, Abhilash says that what is the earliest time frame in which we can actually detect tuberculosis on an X-ray? Sir?
Right. So there is one caveat to that. So whenever the patient has a spinal infection, we don't know when exactly the infection started in the spine. So if we go through the history, some of the patients will say like, I had some back pain about a month ago, then it was all right. Then again, after 2 months, the pain started, because we don't know what is a typical spine in tuberculosis related back pain, or is it a general back pain of the disc degeneration. So typically 1 month since the onset of the infection, the patient can have a features of spinal tuberculosis. Like I told, the earliest sign is decrease in the disc space. This is due to the affliction of the nutrition of the disc. So the disc starts collapsing. You can see subchondral osteoporosis. There will be areas of translucency within the subchondral region. So these are the earliest features by which we can diagnose spinal tuberculosis in the radiographs.
So there is one more question actually. This is from my end also. Sir, based on we do gene expert and a lot of things, and the specificity and sensitivity of gene expert is very much high. But sometimes, like, we get a lot of patients who were empirically started on AKT. In those patients, you get gene expert negative. So can you just share your experience that how much is the culture report at 3-week and 6-week important? Like, what is the importance? Because I still feel that somewhere down the line where we get, those false positives or false negatives in gene expert, the importance of culture is still like the gold standard in our management. Can you throw some light on that, sir?
Exactly. So gene expert, like I told, it is a polymerase chain reaction based test, which looks for the DNA of Mycobacterium bacilli within the infected focus. So even if the bacillus is a dead bacillus, even if one dead bacillus is present within the infected tissue, the DNA will be augmented by the polymerase chain reaction, and it will show a positive test in the gene expert investigation. So a positive gene expert test does not always mean that the patient is having an active live bacilli within that infective focus. But it is a very good sensitive test. So if the gene expert test is negative, that it indicates that the presence of spinal tuberculosis is very less, because it's a very highly sensitive test. A false negative test is very unlikely in gene expert test. So that's why we, whenever there is a positive gene expert test, we immediately start the patient on anti-tubercular treatment, but we keenly look for the histopathological examination. So we look for the Langhans cells, epithelioid cells, and caseation necrosis, and more importantly, the 6 weeks tubercular culture. So that is the one which I am keenly looking forward whenever I have taken biopsy in the patient. So that's the one which is going to confirm the diagnosis.
Yes. So any more questions from Varun, Tarini, say Dr. Mahendranath? So I think, sir, most of the questions. Okay, so we have one more. Sir, do all cold abscesses need to be drained, sir? Is a question from Abhilash.
Yeah, that's a wonderful question. So not all cold abscesses need not be drained. So there are typically 2 indications when you need to drain a cold abscess. Number 1, when the cold abscess is pointing at the skin. So if it is pointing at the skin, then it is going to rupture and create a sinus. So if you aspirate it well ahead, then you can reduce the chance of formation of a sinus or a fistula. And second thing is, whenever the cold abscess is deep-seated and causing a pressure symptom. So for example, if there is a C3 or a C4 lesion with a huge cold abscess, which is affecting the breathing of a child, then again, it will need a aspiration. So these are only the 2 instances. Otherwise, even if you see huge cold abscesses within the paravertebral region and it is not causing any pressure symptoms, we can treat the patient effectively by anti-tubercular chemotherapy. You'll be surprised to see that at the end of 9 months, if you take an MRI and see such a huge abscess would have completely resolved with medications.
Yes, sir. And yes. So no more. I don't think there are any more questions.
Joy is unmuted. Is he going to ask a question?
Joydeep, are you going to ask a question?
No, I think he did it by mistake.
Okay.
Mahendranath.
Yeah.
Surgical treatment in multi-segment involvement of spine. Yeah. So like I told, before the usage of MRI scan, the incidence of multi-level, non-contiguous. So you have an infection in the thoracolumbar region and you have an infection in the upper thoracic or the cervical spine. This is called a multi-level, non-contiguous infection of the spine, was very rare. So the incidence was only less than 15%. But with the advent of MRI and once we started doing whole spine MRIs, the incidence is 70%. So a patient presents with thoracolumbar infection and you see there is a small focus in L5 vertebra and you see a small focus in C7 vertebra also. So you treat the disease based on the individual infection. So if the thoracolumbar infection is unstable, you just operate that level and whatever antibiotics, the anti-tubercular chemotherapy you're going to give is going to have a systemic effect. So it's going to heal a pulmonary lesion. It is going to heal a L5 lesion. It is going to heal the C7 lesion also. So you don't need to operate those levels. So whichever level is unstable and causing neurological deficit, you have to intervene at that level.
So I think, sir, there's some problem with the audio of Joy, but he's texted me this question saying that how aggressive are we nowadays during surgical management, or do we still stick to the middle path regimen? I mean, in the presence of a spine instability.
Yeah. So of late we are little bit pro surgery because those days patients were ready to lie in the bed for 2 or 3 months and were keen to take anti-tubercular chemotherapy. But I think these days with good surgical intervention, because the pedicle screws that have come up and with the improvement in the expertise also, we are able to give better results for the patients through surgical intervention. So any patient with a neurological deficit, instability back pain, with early kyphosis, so surgery gives excellent results. And one more thing, what I would like to add is a lot of people are worried about using titanium screws in the presence of infection. Even if it is a pouring abscess, cold abscess is present in the posterior aspect of the spine, the tubercular bacilli cannot form a biofilm over the titanium screws. So be confident in inserting a titanium pedicle screws in an infected spine with spinal tuberculosis. Actually, stability helps in healing the disease. So you need not be worried about having a surgical intervention.
Yeah. Very, very important point, sir. And I think we've taken enough questions to an already long lecture. And I don't think that you've left any inch or corner of this topic. And it was wonderfully explained. But I thank you. I really do thank you for your time.
Thanks.
With this talk. And I shall see you soon someday, sir.
Yeah. Thank you. Thank you so much, Rohan, and all the students who were with us. Yeah.
Thank you so much, sir. Thank you.